Thank you. I'm going to speak about the rationale for mobile bearings in the revision situation. An example of a 76-year-old lady, 4 years later, that's her condition. And we've used mobile bearing in this. I think in the interest of time, I'll skip this. This is a mobile bearing with a sleeve and stem. And that's a patient at 2 weeks. So how are the results of revision TK and why mobile bearings? So a few papers discussing the results of revisions, 655 revisions in this paper, around 500 in this, and 500 revisions in this paper, and about 1,000 revisions. So there aren't too many series of long-term results. And in summary, 70 to 80% success at 10 years in revisions. Loosening, instability, and stiffness are a huge cause of failures, 10 to 40%. Of course, infection is the most important cause, but loosening, instability, and stiffness. And what's even more worrying, 60% of these revisions are revised within 2 years. So that's terrible. So can mobile bearings actually help in revision? There aren't too many long-term studies on this, but this is a more recent paper, and we have Go-Chin Lee in the audience here. And this is the midterm results of mobile bearings, 300 odd cases at 5 years. And look at the drastic reduction in the number of reoperations. It's down to 10%. And if you exclude infection and crepitus, you look at aseptic loosening, stiffness, and instability, it's down to less than 3% from our original 10 to 40% failure. And that paper includes both the use of stems and sleeves with the mobile bearing situation. But now if you just look at mobile bearings with sleeves alone, the survivorship is over 98% at 5 years in this study, 96% at 5 years, from the Mayo Clinic, and over 97% at 4 years from this meta-analysis of sleeves with a mobile bearing tray. So I suspect the rationale for mobile bearings in revision total knee can be summarized into 5 reasons: the mechanical advantages, the kinematic advantages, stability, a bit about the cam post, and the versatility of this construct. So look at the mechanical advantages. You have maximal tibial tray coverage of the tibia, which is independent of the insert size. The insert matches the femoral size. There's more conformity and contact area between the polythene and the femoral component throughout the gait cycle, thereby reducing the stresses on the polythene. Mobile bearing allows uncoupling of the multidirectional wear vectors, converting them into unidirectional forces. So again, there is less wear. And most importantly, there's decreased torque transfer to the implant bone interface. So you see the X-ray with the loosening of the stem, that should not occur. So now this is a fixed bearing implant. You can see as the patient flexes, extends, and there's some degree of rotation of the femoral component. It impinges on the tibia, and that is transmitting these torsional forces onto the stem, which is a fixed bearing implant, and that encourages it to loosen out. On the other hand, if you have a mobile bearing tray, it uncouples this motion. So these stresses are not getting transferred to the tibial fixation, and therefore you have less loosening. This is also shown in studies looking at the strain distribution on the bone. So if you look at the blue bars, they are fixed bearing knees. The small red bars are the mobile bearing knees in extension and flexion. And you can see the drastic reduction in the transmission of torque to the tibia because of the presence of a mobile bearing. And this is reflected in the lower von Mises strains in the tibia. In a fixed bearing, you can see there are some yellow and red zones, whereas lower down, you can see it's almost all blue when you use a mobile bearing. So now in revisions, when we've seen there's a huge amount of bone loss, mobile bearings can reduce the amount of torque transmitted to this poor quality bone, thereby reducing the incidence of loosening. Also, studies have shown reduced wear with revision with the mobile bearing inserts, with less surface damage compared to fixed bearing, which is on the upper row. You can see with the mobile bearings there's less surface wear. In terms of kinematics, it mimics the kinematics of the natural knee more closely. You can see this patient 6 months after revision with a mobile bearing tray with excellent range of motion. So again, the problem of stiffness can be minimized. Stability. So implants provide stability because of conformity between the tibia and the femur. You can see on the top, you have full conformity, that's 1. And where you have just point contact, the conformity is 0. So with the mobile bearing trays, you have 0.99 conformity. So that gives you an incredible amount of stability. And you can see the amount of anterior translation that occurs. This graph shows that there is a minimal amount of AP movement because of this conformity. Also, it gives you very good varus valgus stability because of the tighter tolerance between the post and the box. Same advantages are there in the rotating hinges as well, because it reduces the transmission of torque to the implant bone interface. So the more constraint you have in the joint, the more forces get transmitted to the bone. You have poor quality bone, so you want less force transmitted to the fixation. And that's the advantage of a mobile bearing. More importantly, we saw in the previous talk, there's reduced stress on the post. So as in a fixed bearing, this is a mobile bearing, it moves with the femur. Whereas in a fixed bearing, you can see the amount of stress on the post. This can lead to post wear and a whole load of fractures, especially a bigger post like a TC3 would be more susceptible to this. So with the mobile bearing, it moves with the femur, so less stresses on the post. The design is versatile, and you can accept different femoral components if you plan an isolated revision. You can add stems, wedges, sleeves to these trays, or even step wedges. And to end, I'll just show you a few examples. Patient with severe pain and instability, marked osteolysis, a lot of bone loss, 80-year-old, bilateral revisions using a mobile bearing tray. And that's her. This is 5 years post-op with an MBT, a PS stem, a PS insert, augment and stem. And this is a case of an MCL rupture where we used a rotating hinge. So in conclusion, you can independently size the tibial tray. It increases the congruity and stability, reduces stresses on the fixation, thereby reducing loosening. You have more natural kinematics and less wear, so more movement, reduces post damage and fracture, and it's a versatile device. Thank you very much.